Buddy. Well, we have an exciting night tonight. I am so excited. I have about 100 questions here for Dr. Miraglia, so I think we may need to do this another night as well. But welcome, Dr. Miraglia. I know a lot of people are really interested in your success and your experience with expanders, fixed expanders, removable expanders. So let's just dive in a little bit and tell us how you got started. Why did you choose to go the expander route in your career after, you did your general residency and your career? What made you go into expanders?
Yeah, so I began dentistry in 1993. I spent 10 years doing restorative crown and bridge, basically full mouth reconstructive dentistry in the fixed variety. And so a decade of that, but over that time, we were sending the children as an orthodontic referral. And then 10 years of watching, the results and, what was coming back, the requests that we were being asked to do, there was a level of disappointment. One thing leads to another, and you take a class and another class, and you're trying to figure out, is this the best it can be? And after a few courses, all of a sudden you realize, wait a second, there's a whole nother level out there to learn. It's about expansive and growth and development type of techniques. So next thing you know, I fall into the category of, wait, I want to learn about expansion. I want to learn about growth and development. And one course leads to the next. The next thing you know, you start finding people that teach these things and can be then your mentor, and you then start to follow and practice according to their routines that they've been doing for a long time. And all of a sudden it's 17 years later. So this is now my 27th year in private practice. The first 10 were doing the restorative crown and bridge fixed reconstructive dentistries. The last 17 years I have been doing growth development and expansive orthodontics, which has led to a 17-year run with non-extraction techniques. So we have never extracted a permanent tooth. We don't even extract baby teeth. So we do not extract primary teeth. We do not extract permanent teeth. And that is an absolute. So I have a 0 extraction rate for the last 17 straight years of treating children. On top of that, what happens when you address the growth and development, the expansive appliances that they offer early, is you start to notice you get an opportunity to keep your wisdom teeth over time. So as the children that we treated between 3 or 4 and 12, all of a sudden become 18, 19, 20, we get to keep their wisdom teeth. So we watch those wisdom teeth erupt, and if they need a little help erupting, what has become a really nice referral is I send the 18 to 20-year-old to the periodontist, and what they have is a wonderful technique to do the laser on the surface tissue. So the moment the first cusp breaks, we send them to the periodontist, they laser off that occlusal tissue, and next thing you know, the wisdom tooth can pop into place. So now we're experiencing the opportunity to get 32 teeth in there. And so that really is, that becomes the beginning goal, is that we'd like to develop the human being as big as we can, which should be normal, considered normal, to have 32 teeth. As it turns out, these things are so related. When you have 32 teeth where they belong, you've got the right foundation. When you've got the right foundation, you have the ability to breathe very well through your nose, and your tongue has an appropriate amount of volume in its chamber to fill in. So the idea there is, over the last 17 years, one piece of the puzzle fell in at a time. I've had a lot of mentors over the years, and it led to a spot where we are today, where it's probably 90 to 95% of what I do is to get children growing and developing, breathing and sleeping, and treating the foundation first with the teeth second, and having an opportunity to not only have 32 teeth, but to be a nose breather and a good sleeper, and basically lose all of the symptoms that come from sleep disorder breathing. I see you've got some appliance pictures there.
Yeah, I think, we have so many questions on the appliances, so rather than talk about it, let's show it, and I have a feeling you'll be able to answer a lot of the questions as we go. So I know one of the running questions is, when you use fixed expanders compared to removable expanders? You want to just give a quick overview of that, and then we'll go into the actual expander?
Yes. Yeah, so generally I use fixed expanders on children and teenagers, and I use removable expanders on adults. And so while removable expanders do work on children and teenagers, I'm not a fan of the compliance issue when it comes to removable expansion appliances in children. So I go right to fixed expanders. The earliest that I will use a fixed expander is going to be about 6 years old. Predominantly, it's between 8 and 12, but we have used expanders that of the fixed variety all the way to 17, 18, and 19. You can have them at those ages. You just need an appropriate technique. This happens to be my favorite one. This is, an upper fixed airway appliance, as we would call it. Technically, it's an expander. That little mechanism in between is a hexagonal shape. It's called a super screw, but it's two-banded. It goes into the upper arch, and it can deliver, a nice 10 millimeters of expansion. So this is my favorite or go-to type of expander for the upper arch, and I use that. That's 99% of the time. That's the expander that we're using.
And what age would you recommend starting this appliance with? That was a running question.
Yeah, predominantly it's 8 to 12 years old is a really nice range to be using this in. I've used them as young as 6. I've used them as old as 17 or 18. And it's not so much about there's one best time to do it. The idea is, diagnosing your patient appropriately and then figuring out, what is the level of underdevelopment of the jaws doing beyond the teeth? Because when you have underdeveloped jaws, you're looking at crowded teeth. Everybody sees the crowded teeth, but the underdeveloped jaws are what is delivering developed jaws. Typically, you're going to see some sleep disorder breathing. You're going to notice that the airway compromise relates to the sleeping, and that child is going to show up with some level of symptoms. And so we would take a look at a child and figure out, do they need a slow path because their symptoms are mild, at which point removable guidance appliances could be used, or does that child have symptoms that they've been struggling with for years, and maybe we should think about correcting them in weeks instead of months to help with the so-called medical symptom list that might come with some of these children.
Okay, so let's take a look at a sample case. Do you want to tell us a little bit about this case that you use the fixed airway appliance for the upper?
Oh, sure. So this is a perfect example of using that exact appliance on this child. And here we're looking at a before and after expansion. And so on the left side of the screen, what you see is a narrow arch with a high vault and the crowding of the teeth. But what we don't get to see is, taken from the history. This is a child who began the struggles with the breathing at 2 years old. And by the time we're 2 years old, the tonsils and adenoids had to be removed. And then, of course, that didn't help that child. So they struggled to breathe and sleep. The history is that they don't sleep through the night. And of course, by 6 years old, we learned that the child was offered medication to help with the symptoms they had. By the time we're 7, 8, 9, the medication list is being added to. We don't meet this child until 9 years old. So here we have this 9-year-old child coming in with this malocclusion of the underdeveloped variety, a very narrow arch, crowded teeth. But meanwhile, when we take the history, we learn from the parent, this is a child who hasn't slept through the night yet. So here we have a 9.5-year-old that the parent will tell us hasn't slept through the night yet. We're dealing with a chronic and debilitating condition that this child hasn't slept through the night and is on multiple medications to control the symptoms. So of course, if we're going to have a shot at developing this foundation, it's going to go to expanders. We would like something a little more rapid to get that child, out to where they belong. And what you're looking at, of course, is the after the expansion, and everything is different. Yet the teeth are aligned, which is nice. But it's really the palatal vault that's different. When you're looking into that arch, you can see that we don't have a high vault anymore. All of a sudden, we have a broad, wide, dome-shaped vault that's shallow, not vaulted. Well, the difference there is the difference between mouth breathing and nose breathing. On the left at the beginning, that child's vault is so high they cannot breathe well through their nose. So that airway compromise produces the compensating mouth breathing. The mouth breathing triggers the difference in the sleep quality. Now on the right side of the screen with, having a 10 or 12 millimeter expansion technique, all of a sudden we have the opportunity to have the arch, fully develop, but the vault come back down. This opens up the nasal cavity. Next thing you know, this child can breathe through the nose. As the child can breathe through the nose better, the sleep quality improves. So having had that expander over the course of, we think about 6 to 9 months, the first few weeks are active. An expander at this age of 9, activity might be 4 to 6 weeks. The distance is achieved. We have our position. We hold it a little longer. We use little braces to line up the teeth. But once we have this amount of growth and development, we expect a difference in the breathing, the sleeping, and the symptoms. And sure enough, this child's symptoms fade away. This child had both an upper and a lower expander. So when you look at this picture, this is a picture of the lower expander. Now, the reason it's a set of expanders is because if we're going to make that big a difference in the upper arch, the lower needs to follow it. So when we think about having an upper expander, the lower teeth are in a certain position, and usually the bite connects. It's not a good bite because we're very narrow. But the moment we deliver an upper expander, if we're thinking about getting a significant change in the breathing and sleeping, we're going to want to have an 8 or 10 or 12 or 16 millimeter change depending upon the child's credentials. And again, the goal is to have the symptom list disappear as well as all the teeth find their home. Well, if we're going to change the top that much, how could the child bite down, right? If you think about how your teeth come together, you've got the top and bottom teeth meeting. All of a sudden, if you're going to do 10 or 12 millimeters of upper expansion to get your breathing back and get your sleeping back, well, the lower teeth had better follow in order to keep a nice bite, so to speak, on the back teeth. So this lower fixed appliance goes in, and this would be turned a little bit slower, that's all. So we would turn this a little bit slower. We might activate that once or twice a week. The goal is to get the upper rolling because you get your breathing there. When you get the lower rolling, you keep your bite going. And again, over the course of 6 to 9 months, you develop that entire arch. And I think we do have a follow-up photo that shows the difference in the lower arch for this patient. Here we are with the lower. Now we could see before the expander, we have the central incisors coming in all over the place. 23 is out of position. 26 is way back there out of position. And sure enough, that's the starting point. Now with that lower appliance, we're able to upright and open up the arch. Now, when the arch opens up, you maintain your bite on the back teeth. You can have your 10, 12, or 14 millimeters of expansion, whatever you need. And the idea there is once you open up the arch, you can have those front teeth take their position. So here we are, and this would only be probably about 10 or 12 months later. The expanders are already removed. And then we turn our efforts towards our nasal breathing, our muscle activity. So a lot of orofacial myofunctional therapy gets included in these cases as well, so that we can start to get our muscle balance and our muscle education correct. In the end, what we really need is the foundation. It's, we need to help that grow. But then after that, we need to support the things that should have grown it in the first place and start to correct those. So we do a lot of the OMT, the orofacial myofunctional therapy, is a part of all of these kids' treatment. And so whether we do a little bit or we refer, which is predominantly what I'm doing, I'm sending out to orofacial myofunctional therapy people in the community because they do a wonderful job and they do it better than I do. So I'd rather have the children work with them. But the idea behind having the 2 expanders allows the entirety of the arch to improve. Now, we see nicer teeth, we have a nicer bite, but what we really have is a significant increase in volume for the tongue. All of these teeth and the foundation spreading out like this mean all of a sudden we're going to have a lot more room for that tongue. The upper expander opens the nasal cavity. Now we can breathe through the nose better, but that doesn't help much if the tongue is still sitting back. So all of a sudden we have this chamber that the tongue is going to really enjoy having, but we need to be able to breathe through the nose, so we need that vault to come down. So the upper expansion appliance opens up the arch, brings the vault down. Now you can get the air in your nose. The lower expansion appliance opens up the chamber so the tongue can actually fill.
I think we lost your volume just a moment.
Ready in college. So the end result is we get to college and we don't have the symptom list that we started with.
Okay, so let's take a look at this case because this is quite the case, right?
Oh,
There's no way you can
favorite.
stand this case, right?
Oh, of course. No one could do it.
No one, that's what we hear, right?
No one,
that's what they tell us.
That's what they told us.
So let's take a look. Want to do your magic?
Yes, so the idea here is we're looking at a 16-year-old. And so this is 16 who received no attention because the parent refused to take out the teeth. And so what we learned when we met this child at 16 years old was that they went places, they went here, they went there, they went everywhere. So there you have, a tribute to Dr. Seuss. But the idea is this child was seen and was offered extraction. The parent refused extraction, did not want extraction. Do you have another option? Surgery comes up once in a while, but mostly they refuse. So here we have someone who has an upper and lower arch with, maybe it's called moderate crowding, maybe it's called severe crowding, maybe it's called astronomical crowding. I don't know what you call it. What you call it is you have underdeveloped jaw structure. So you have an underdeveloped maxilla and an underdeveloped mandible. Basically, you have underdevelopment. So I don't see crowding anymore. I see underdevelopment. So I see and meet a child like this, and you know where we're headed. I don't do extractions. So this child's already been treated, obviously. So since I don't do extractions, we get expanders in there. So all of my expanders are similar in that we have that upper fixed super screw technique. We're going to go ahead and start turning that, and the anterior arms will help to shape the arch along there, and the lower one fits in too. You just have to put in your little spacers and make it work. So you get these in there, and then this was such a narrow arch, we had to go through 2 rounds. So the first round can get us about 8 or 9 millimeters, and the second round is going to get another 10. And so we're going to deliver a significant change, which you're about to see in the photographs in a 16 and really going on 17-year-old person. So there's
Just like
no room
that.
for that tongue whatsoever.
Magic.
Just like that. Yeah, it happens like that overnight too. Overnight, you know, you put the expander in on Wednesday, and on Thursday they look like this. So the idea is that, I'm kidding, and I hope everybody understands that's my, you know, dad humor. But anyway, this is not the next day. You know, this is obviously months later. Now, a 16-year-old that we meet gets fixed expanders, and with an appropriate technique, we can go through 2 rounds of expansion and be here. Now, if this patient were to walk in your door, we would look at that and say, oh, wow, I'm so happy I'm getting a clear aligner case. I'd like to do Invisalign. I want a clear aligner, clear correct. It doesn't matter which one, they all work on, but here we have a clear aligner case right here. Well, the fixed expansion appliances can deliver this, and then this gets clear aligners to finish up. Now, this child has room for their tongue. This child, the difference between the first photographs of all that crowded is that you can't breathe through your nose. If that's how you look in those first photographs, there's no way to breathe through your nose. And now you're going to have the mouth breathing. The mouth breathing is going to give you your sleep disorder breathing, and you're symptomless. So all of a sudden, you take this child from here to here. And what we're looking at here is a matter of months later. So we go through 2 rounds of expansion to develop that maxilla. And now I have a foundation. With a foundation comes the opportunity for tooth alignment. So the simple process is that we do foundation first, teeth second. Foundation first, teeth second. It's not about the teeth. It's about the foundation. So when you address the foundation, then you get to make it about the teeth. That's always second. And then we have the opportunity for a very simple clear aligner case. What a treat that was, right? Just get the expander work done, and then you get to put in some clear aligners and finish aligning these teeth. Now she's going to keep all these teeth.
You know, and this
So here
patient,
we
she
are.
probably never thought that she would have a smile like this. You know, she has beautiful teeth, just in the wrong place.
Yeah, and they had enough consults to know that no one was going to offer a non-extraction technique. It was have to extract teeth or else there's no other choice. You have to extract teeth, there's no other choice. And I hear this weekly. This is not a fluke that this patient comes in. It's weekly. It's so weekly that it was this afternoon at 4 o'clock, because the 4 o'clock patient is the 12-year-old that's brought into the practice for consultation because, well, at 7, they had a fixed expander, but then had braces for 4 years. And after all that early work to help the teeth fit, now they're told at 12 they have to take out the 4 teeth. So who wants to hear that after they went through all these 5 years? So the 12-year-old gets in the chair at 4 o'clock because they want to know, can we do this without extracting any teeth? Because we were told now we have to extract teeth, and then you have to hear their whole, you know, and it's upsetting because they're not happy about it because they've just worked on this trial for 5 years and they've delivered something that now needs the teeth taken out. So I understand the frustration. I have to meet these people every week. The idea is, well, by 5 o'clock, we're finished with a full consultation, and now that child will start treatment and get the necessary expansion appliances that she needs to develop the entire arch to not take out the teeth. It's a weekly routine now, but this is the difference in the lower with just 2 rounds of expanders. We go from 1 to develop enough to get the second one in. So this child goes through, 2 sets of these expanders, upper and lower, and then all of a sudden you're here.
And this is from our friend, Kevin Ohlendorf.
Oh, yeah. So Kevin Ohlendorf Appliance Laboratory. That's where I get all of my appliances from. And so, this was one of the probably more challenging ones that he gets to make, but he made it and I inserted it. And, that is a wonderful opportunity to get some very nice appliances. So Ohlendorf Appliance Laboratory has been making my appliances, I would say about 10 years now. So I met Kevin a long time ago. I began making expanders with him in both the fixed and removable category. And I've had such a positive experience being able to deliver treatment like this, thanks to his appliances, that I can't see myself using a second laboratory right now. So he's got a beautiful lab. Very happy.
Well, I hope he's watching. I think he is. So I'm sure he's smiling right now from ear to ear. Okay, let's look at the upper removable 2-screw airway appliance. Tell us a little bit about this. I know about this because I'm currently in treatment myself.
Yes. Yeah, you're wearing that. So
well,
basically
I didn't wear it
this
tonight,
year is Oh, yeah, yeah. You don't have it in now. That's okay. We're going to put it in after the meeting.
Right,
Okay,
exactly.
so the upper removable two-screw airway appliance. So this is a removable appliance. It basically has, a couple of clasps on the side that are going to give it some engagement. It has some palatal vault coverage and lateral coverage, but the design of this appliance is made so that over time we can remove the vault acrylic, because with the proper technique, we can insert one of these and teach a patient how to use it appropriately to grow the foundation. And so when you grow your maxilla, when you grow your foundation, you end up breathing better. And so not only do you solve your breathing, your sleeping issues, you get your malocclusion corrected. You have a whole long list of things. But again, foundation first, teeth second. So this is a fantastic appliance. It's a wonderful opportunity to grow the foundation, and we use this at any age. And I think we might have an example of it coming up too.
Coming up. Did you get
Oh,
it yet?
yeah. Oh,
Here we
another
go.
one. So, yes, so this is what it looks like when you've used that appliance for about 9 months. And so here we have a patient who we meet at 19. So when you're 19 years old, you're getting a little older, we choose a removable expansion appliance. And when they come in, they have a history of having their braces and it didn't work out and whatever it was. But meanwhile, the foundation wasn't addressed. So if we take this patient and I like to measure across the arch, and that's what the 27 to 34 is. 27 millimeters is the distance between 3 and 14, the upper molars. Now that removable two-screw appliance delivers that first 7 millimeters of change there. So we go from 27 to 34. Now, 9 months later, with the 34 millimeters across the arch, we can transfer that patient into a clear aligner. The clear aligners can deliver further expansion so that we can finish with a 10 millimeter change. So we're looking here at the difference between the palatal vault. On the left side of the screen, that vault is pressed up higher, almost like the thumbprint had been pushed up into the vault. That's a higher vault. When we look at the right side of the screen, that removable airway appliance was able to develop not only the width, but it rotates the vault down. As the vault comes down, we've got wider and a lower vault. You know what that means? Better airflow through the nose. So all of a sudden, while we're developing the maxilla, we get better airflow through our nose. If we can breathe better through the nose, guess what? Less mouth breathing translates into better sleeping, translates into less symptoms, and a lot of symptoms fade. This particular patient, the number one symptom was the headaches. And so when you have headaches weekly and they're debilitating and they're, interfering with your quality of life, that's a significant issue. What you're looking at here is the difference between significant headaches weekly to none. And the headaches began to diminish within 4 weeks of beginning the appliance. And by the third month, well, I call it a child because it's 19, but this 19-year-old patient had no headaches at the third month of treatment. This patient is also 4 years out of treatment. So we have now 5 years since we started this case. We're 4 years out of treatment, hasn't had a weekly headache since. So we're in great shape here because of the development of the upper jaw. And I believe we have the next photograph to show where this went, because this was just the upper removable expander, but then we had to go ahead and do some clear aligners to coordinate the teeth. So we end up getting a few more millimeters from the clear aligners. So now we're at 37. So what we're looking at is a 10 millimeter change in the width, which delivers a huge amount of volume increase for the tongue. Next thing you know, the vault has dropped down, so it's not as high. You could recognize a little bonding. The teeth number 7 is undersized, a tooth size discrepancy, but 10 was actually like a peg lateral. So we put some composite. So we're looking at someone who's used a removable airway appliance first, aligners second, but with the clear aligners, we throw the whitening gel in there. So you could see the shade is a lot lighter. So we're going to see bonding on 7 and 10 to give them the appropriate width because they were too narrow. And probably the next photo shows the difference in the occlusion. Yeah, so here we have the end result. Now, on the left side of the screen, we have a patient suffering from weekly headaches as the number one chief complaint. We have an underdeveloped maxilla. We have a crowded malocclusion. And so the list goes on, but the symptoms are significant. Upper removable airway appliance, develop the maxilla. Switch into clear aligners, coordinate the teeth for the bite. Remember, foundation first, teeth second, and then if 7 and 10 happen to be undersized, throw a composite. Now, we use composite at first because we want to make sure that we're perfectly stable and the patient has no symptoms. Eventually, those will become 2 nice veneers, but I haven't done the porcelain veneers yet. We're still sitting with composite on 7 and 10. But the rest of her teeth outside of 7 and 10 are all natural enamel She just had a very nice result with the whitening gel. So it's whitening gel on everything except 7 and 10. That's my own composite on those teeth. What we end up with having the foundation to then coordinate the teeth is such a beautiful occlusion with a home for the tongue and the nasal breathing with the sleeping. Now we're headache free. So now we've got a child from 19 to 20 that we treat her. All of a sudden, you have someone who hasn't had a headache in 4 years, thanks to having, you know, growth and development technique and expansion technique.
Great. Okay. Beautiful case. So let's talk a little bit about the lower removable appliance. When I know we don't use this frequently, I'm actually using this because I wanted to try it out because I used aligners too, just
Sure.
to kind of see what it feels like to help the patient with patient education. So tell us a little bit about when you would use a lower removable appliance in conjunction with the upper.
Yes. And I think we have a photo of one, right? Yeah, there we go. So now, with regard to adults, it's very common to have an upper removable airway appliance because the maxilla needs development. The maxilla is really the key to breathing because we need the nasal chamber back and we need the palate opened up for the tongue space. It's interesting that in the lower arch, it's mostly lingual inclination. So the back teeth are kind of leaning in. So I like to get into clear aligners because the clear aligners are really nice at uprighting the back teeth. So we find that predominantly the pattern is an upper removable airway appliance to grow the maxilla and lower aligners to upright the teeth. And every now and then we do make a lower expansion appliance, and this appliance here with the right technique will also help with the nice dentoalveolar remodeling. What you're going to get is growth. So we use this appliance less frequently, but we use it enough to know how wonderful it is. And certainly when we deliver this appliance, we're going to have a technique that allows you to grow that lower as well, so you can kind of keep up with the upper. So that's a nice appliance too. If you basically would think about it, if you don't think the clear aligner will give you enough uprighting, then you use this. And then if you try the clear aligner and it didn't give you enough uprighting, switch into this. You almost can't make a mistake. It can help you if you need the uprighting.
Right, and as far as comfort goes, I was surprised how comfortable the lower appliances were. Very smooth. So as far as compliance goes, especially working from home, it's really not, I like having the break, kind of not having to wear an aligner 24/7.
They're not supposed to hurt.
Right.
They're not supposed to hurt, yeah.
Mm-hmm. So far, so good. All right, let's talk a little bit about the 3-screw sagittal airway appliance.
Yeah, so this one adds another component to it. So we know roughly we know our percentages, class 1, 2, and 3, right? So class 1 and 2 under development we see most often, and then whatever percentage you were taught or believe in, the class 3 might be 3%, 5%, 7%, wherever the class 3 is. When we have that class 3 component, then we think about a 3-screw upper removable appliance because now we'd like a little anterior push too. So all of a sudden we switch into a 3-screw for our class 3 patients. So the class 3 has a more seriously underdeveloped upper jaw. So we start to use this appliance. This is going to give us our width as well as our premaxilla forward growth. And again, with a nice technique, we get that vault to come down. So any appliance that is developing by expansion, if it's widening, you're going to get some forward movement. So you get a little forward movement just from lateral force alone. So a 2-screw appliance will give you some forward movement. I will use a 2-screw appliance for the patient who's edge to edge in their bite. So an anterior edge to edge bite, the 2-screw will probably do it. But when you've got the full class 3 connected anterior crossbite class 3, we switch to this. And with this appliance, we can open up the upper arch even bigger and wider and forward. And next thing you know, you have an opportunity to get that patient back to the normal top teeth overlapping bottom teeth. In the end, it's about developing the arch enough to make a difference in the tongue space and the breathing through the nose, because that's where you're getting your symptoms from as the sleep is compromised, thanks to the airway being compromised, thanks to the underdeveloped jaws. Again, it's the same thing. It's foundation first, teeth second. We don't look at the teeth very much anymore. We look at the foundation. After the foundation, we take care of the teeth. That's step 2.
Terrific. Okay, so that's just review some of the cases. We have tons of questions, but before we get to the questions, I just wanted to brag about our Airway Health Series mini residency that you teach. We have them coming up. We have it in 2 days now, where you can have a pedo course and then an adult course, but we prefer you take them together. We have courses in October the 16th and 23rd, November 6th and November 20th. Please feel free to go to our website to learn more about it. Also, if you wanted to see a little bit of these cases in more depth, you can go to our webinar. It's airwayhealthsolutions.com/webinar, where you can see a little bit more of the before and after and more of the details. So feel free to reach out to me at our website. I'll be happy to tell you more about our mini residency. I also want to share a special announcement that we just added a key team member to Airway Health Solutions, Brittany Sierra. She's an orofacial myologist, and she'll be able to help our Airway Health Solutions clients with telehealth to do myofunctional therapy, especially in those remote areas. So stay tuned for more information on that. I will be actually doing a conversation where Brittany's going to play host, because we're going to talk about airway health and airway ortho, the role of the hygienist. So doctors who are listening today, you want to get your team and hygienist on board. Tune in tomorrow night with same format, where it'll be conversational, and they can learn about airway screening in a really simple way. And then we also have another conversation October 7th with Dr. Miraglia, where Brittany will be hosting as well. Just talk a little bit more in depth about your journey and interdisciplinary collaboration. So this is all helping to raise awareness of airway health, and we really appreciate Brittany and also Dr. Miraglia. Another announcement, because it's this week and it's so exciting, is this Global O2 Day on Friday. So the Foundation of Airway Health, I know Howie Hindin's going to join us later in the evening. I hope he can jump on. I know he's very busy in preparing, but we will give you the links to get your free virtual ticket. It's Global Airway Health Day. Dr. Miraglia, you want to talk a little bit about airway health awareness and what your goal would be in 5 years from now, if you can kind of see where the airway health awareness would be 5 years from now, what your vision would be if you had a magic wand?
Oh, this would be common knowledge. And so it's almost disappointing that we're in a spot where most of society doesn't even understand yet that mouth breathing is harmful or unhealthy. And so when you're breathing through your nose, you have the opportunity to be a healthy human being. So, the entire day and night, there's opportunity for the mouth to do some compensative breathing. But the idea there is any little bit of mouth breathing throughout the day or night is going to trigger a response by the body. And that response is in the sympathetic category, which delivers an inflammatory reaction. So when you're dealing with mouth breathing on even low levels, you're dealing with chronic and also long-standing sympathetic and inflammatory response. The idea is this Breathe-A-Thon, what we're hoping is that with each step of the way, the awareness grows to the point where it's common knowledge that human beings are obligate nasal breathers. Mouth breathing is the most unhealthy thing that you could do as a human being. It's a silent killer because it chips away a little at a time and you don't realize it, but it takes a toll on every system in the body. And the mouth breathing that goes on, whether it's day or night, is wildly unhealthy in adults. And it's worse in kids because they're growing and developing. So I would hope, if I could wave the wand, I would say I would hope it'd be less than 5 years that everyone understood the opportunity to convert from mouth breathing to nose breathing does exist. And that it would be common knowledge that in order to be a good nose breather, you have to have a foundation that's grown big enough to allow the air to pass through well. And then that would, lead people to receive treatment that's appropriate in the growth and development category so they could be a better breather, better sleeper, healthier human being. All of the things that lead to healthy come from nose breathing, and all of the things that are unhealthy are contributed to by mouth breathing or worse. I say mouth breathing because it's the beginning of trouble. Mouth breathing can become worse and go all the way to the OSA category. Obstructive sleep apnea is a disaster. But even the mouth breathing at the beginning of this whole cycle, it's got to start somewhere. And we're hoping that this is the place that starts and takes off like wildfire. This would be awesome if everybody got this knowledge.
And thank you for all the work you've done to help promote airway awareness. I know we've trained over 100 doctors, and those doctors have treated over 100 patients. So kudos to you and all the work that you've done. So we hope everyone would consider maybe donating to the Foundation of Airway Health, and I'll have those links. I'll send them out to you, or you can visit the website directly. So hopefully Dr. Howard Hindin will join us later. I also want to let you know that I am creating an airway expansion journey blog and vlog where we have videos with Dr. Siegel and myofunctional therapists. I'll be meeting with Propel, and so that's updated, couple of times a month, so feel free to follow us and use the videos for patient education. I'm a dental hygienist, so I'm coming from a patient point of view as well as a dental hygiene point of view. So I try to make the explanations simple on purpose so they're patient friendly. So feel free to visit our blog. Okay, so now good. I think we're right on schedule here. We have about 20 minutes for some Q&A. Oh, Michelle wanted to know, did you mention how often you turn the appliances for pediatrics or adults? Can you just kind of recap that? She missed that.
Sure. So for the younger kids, those fixed expanders could be turned once per day. And so that's the most rapid rate I'll do it. There is a technique where you could turn it 3 times a day. That's very rapid, so I'm not as comfortable with that. So once a day is good. As the children get older, that turning rate comes down. So as we start to go from 8 to 12, all of a sudden we might want to turn that a little slower. So instead of every day, we might go to every other. You get into the older teens, and next thing you know, you're not turning it every day or every other. Maybe you turn it a couple of times a week or 3 times a week. So the idea there is you're going to reduce your turning, and then, you know, it's not just that appliance alone. Well, if you're working on nasal hygiene, myofunctional therapy, Frenum release, you put together a few other things, and next thing you know, you get a few pieces of the puzzle going. But the turning rate in removable ones is a little bit different. And so for adults with removable appliances, we're only turning those once every 2 weeks. And so once every 2 weeks, those get turned as we gauge the progress and the compliance and how well that patient is responding to those. We might drop that down to a 10-day interval. There's, in some rare cases, a possibility for a weekly adjustment. You know, the key is to be making your adjustment, your turn, so to speak, at a rate that allows the bone to grow versus just grow your appliance out of the mouth, because that doesn't, you know, get anything accomplished. So 2 weeks is the distance between the turns for removable for adult.
Terrific. And Dr. Haydar wanted to know, how much expansion can you do with clear aligners if patient refuses an expander? And can you safely do full body movement if tipping is not enough?
So yeah, if you know, we have a consultation with every patient to gauge, you know, their interest in complying with the removable appliance. So for adults, we sit down and we talk about the opportunity for a removable appliance to deliver a certain result, and it has a bigger effect on the bone, so the foundation is more involved. But we do have adults who, based on either work circumstances or social life, who can, you know, say confidently they can't wear a device like that so many hours a day. And it's not the easiest thing to speak with. So next thing you know, we go to next level, because we don't dismiss the patient and say we offer nothing. Well, we say, okay, if we can't use a removable appliance followed by aligners, then our next level is going to be aligners alone. Aligners alone can make a significant difference in the volume of tongue space. And so in the last, you know, I've been using the Invisalign clear aligners for now, oh boy, it's got to be 17 years also. So 17 years of using clear aligners. And I have done a significant amount of expansion. I can give you 6 millimeters, 8 millimeters, 10 millimeters. I can show you cases where we've delivered 10 millimeters with clear aligners. It depends upon that patient and, you know, their age and their willingness to wear those well. Sometimes other techniques are used, because you can do a Frenum release with clear aligners. You can do nasal hygiene with clear aligners. You can do a propel technique with clear aligners. You can do myofunctional therapy in any adult, really in any human being. So clear aligners alone are very capable, but then go ahead and give a patient a Frenum release with myofunctional therapy and nasal hygiene. Guess what's going to happen there? You're going to get the tongue recruited to do the work for you too. So it's never just the clear aligner alone. Maybe we don't get the removable appliance, but a clear aligner alone means, let's talk about what else we can add to this. Can you do propel, MOPS, or a pulsation device? There you go. You got that on your side. Does the patient need a Frenum release? Can they do myofunctional therapy? Can we get that nose clean and empty and breathing better? Maybe some sprays, maybe a septum repair. The moment you have all these other pieces in place, you have the opportunity for a more expansion technique with clear aligners. So never just clear aligner alone, and you can do some wonderful things. As far as the tipping versus translation versus torque, that's getting very technical and more than this 1 hour would allow. But the idea is you could do anything with the clear aligner. And so whatever's possible has probably been done by somebody, and I've either done it or seen it. But the clear aligners are a pretty amazing opportunity because they give you a chance for expansion orthodontics. Clear aligners can give you wider and forward. So there's a wonderful choice for someone who can't use a removable type of appliance or even a fixed appliance. Go to clear aligners as your next best choice. It's still going in the right direction.
A common question that we have is about bone remodeling. Are you getting bony expansion or just tipping of the teeth? How much bone remodeling occurs?
A lot, because what you're getting with clear aligners, it's a removable technique. So with a removable technique, what you're getting is cycles of pressure and tension. So the difference between fixed, like bracket and wire, and clear aligners is that brackets and wires are on 24 hours a day. There's no relief. You always have a pressure on one side and tension on the other side kind of thing. So when you apply a force and it's constant, you have a chance for moving teeth through the bone. Now, the short story is the best way to avoid moving teeth through the bone is have cycles of pressure and tension. So when you're wearing your clear aligner, they're delivering an amount of force to move the teeth. Well, when you take your aligner out, there's an instant relapse effect. So if you think about putting aligners on, it produces, let's say if we're in an expansion technique, it's going to produce pressure on the buccal and tension on the lingual because the back teeth are going to want to do this. So as the back teeth are widening, you have pressure on the buccal and tension on the lingual. That's when your aligners are in. But the moment you take your aligner out, the teeth are starting to relapse or collapse back in. The motion in puts pressure on the lingual and tension on the buccal. By having a removable orthodontic technique, what you're getting is cycles of pressure and tension on the buccal and the lingual, and that's where you get your bone growth from. So the manner in which teeth are moved through the bone and or roots are damaged and or recession is caused comes from fixed techniques. So with fixed techniques, we have a risk of root damage, gum damage, bone damage, because the teeth are moving through the bone because there's always one side have pressure, one side has tension. As far as removable appliances go, it could be clear aligner, could be removable expander. As long as it's removable, the key is removable. So if it's removable, you have an opportunity to cycle pressure and tension. When you cycle pressure and tension, you get bone growth. That's how bone grows, cycles of pressure and tension. I didn't start to learn that until I started talking to my orthopedic surgeons. And as soon as I started talking to the orthopedic surgeons, then you're reading the right books and you're learning about bone growth. Bone grows by cycling pressure and tension. And so that is a full day lecture to go over exactly how all that happens, but stay in the removable category and good things happen.
How many hours a day do you suggest wearing the removable appliance? I can answer this, but go ahead.
Yeah, you should know that answer. Yep. So, we sleep with it, so we get those hours in. But basically during the awake hours, we're looking to have it in half the time and out half the time. If we got 16 out of 24, that's great, but it's not 16 in, 8 out. It's not continuous. What I like to do is cycle the pressure and tension. So we try to wear the appliance for 1 to 2 hours, but then remove it for an hour. Out for an hour, then back in for an hour or two, then out for an hour, then back in for an hour or two, then out for an hour. Now, that cycle, when the removable appliance is in, it's putting pressure. So now you've got a pressure effect. But the moment you take it out, there's release. Release, now that's tension. So what you're doing is you're going to tease all the sutures of the maxilla to allow them to begin a process that involves growing rather than tooth movement. So you want to get that maxilla to grow and you want to get it to happen in all the sutures and you want that vault to remodel. You want to cycle your time. And so it's not good to wear it 16 hours straight and take it out for 8 hours. It's very effective to cycle hour and 2 at a time, wearing and removing, so that you can then generate the cycles of pressure and tension that give you the best opportunity for bone growth. We use them at any age.
So our friend Dr. Kim has a good question. How is it different for kids and fixed expanders, the bone growth, if it's not intermittent? Hopefully you are unfrozen.
Yeah, the fixed expander in kids, we have no maturity in any of those sutures. And so, when you're younger, oh, is that coming through?
Yeah, coming through.
Am I back yet?
You're back.
I hope I'm back.
Yeah, a little off sync.
All right, there we go. So in fixed, okay. With children, the sutures are immature. And when you have immature sutures, now you're going to turn that expander at a rate that is not so rapid, but it'll give those sutures a chance to grow and remodel as well. Now, The children who get fixed expanders don't have them for very long. It's only a matter of a few weeks' time where you've so-called divided that maxilla out to where it belongs and allow it to grow back together in the middle and at every other suture. Basically, what you're doing is you're getting that child caught up to where they should be, but you're putting every other step in place.
Just tuned out. Stand by.
Sorry about that.
That's okay.
Hopefully we're back.
You're back.
Yeah, the idea with an expander for a child is to get that maxilla caught up to where it should be and then turn it over to the tongue, which is why the nasal hygiene exists, the frenum release, and the OMT is all there. When you put all those things in place, you're taking that expander out to then watch that child continue to grow if you recruit the tongue. The tongue is what should be doing that job. We get them caught up rather quickly because we're talking about weeks and we might have that expander in for a couple months or a few months, but we want to turn it over to the tongue. Now, if you use a fixed expander in a child and take it away and you don't address the tongue, most people in dentistry know what happens. It goes back. Everything comes right back to the start because what's happening is the tongue was weak and dysfunctional and the outside or extraoral muscles got recruited. They became hyperactive and strong. So of course the child didn't grow because the inside is weak and the outside is strong. We put expanders and we push them out. All right, so we pushed them out. That means nothing if you don't recruit the tongue. So now you need the tongue in there, educated and strengthened to do its job to continue pushing out. One level past that is you need that myofunctional therapy to get the cheek muscles broken up and taken away from the swallow. If you can get that proper swallow back, which is the compression and vacuum that the tongue should be doing, and you can get that proper tongue function going without the recruitment of the facial muscles, guess which way the kids go? The inside is strong and proper and the outside is not functioning when you're swallowing, the child continues to grow bigger. So the fixed expander in a kid is basically a temporary measure to get them caught up to where they should be so that we can then get the musculature and the breathing to take over and deliver 32 teeth with a full foundation. Every human being should have the opportunity for a full foundation. 32 teeth is the proper count of teeth. So those of us in dentistry just start to focus on the 32 tooth count as being a gold standard. And prior to that, what you need is the foundation to hold those teeth. So foundation first delivers the breathing and the sleeping of the child. Having 32 teeth is wonderful. And so the difference between the expansion appliances in kids, removable expanders work just fine. I've learned over time the compliance issue wasn't worth the distance of time and the separation of symptom from unhealthy to healthy. So I only use fixed expanders in kids based on the symptom list and the desire to get rid of that as soon as possible.
And then what age would you switch to the removable?
Well, usually what we do is we get into the fixed expander and out of the fixed expander as soon as possible, and we transfer the child into removable guidance appliances. An example of those is in the MyoBrace category. So MyoBrace makes nice removable guidance appliances. So once the expanders come out, we transfer that child into a MyoBrace type appliance or similar, and with the nasal component, the frenum release, the myofunctional therapy, when you put all those pieces with a guide, we call them guides, with a guide in place, all of a sudden now you just basically watch that child continue to grow through 12 years old. No child gets a retainer because there's no such thing as the child isn't growing. Every part of the child's body is growing. So we don't put a retainer in any human being who is still growing and developing because the jaws are supposed to be getting bigger by bigger by bigger. So when we use a fixed expander in a child and get them caught up, next thing is all of the pieces that can be put in place to continue the growth and development, which means the breathing, the musculature, frenum release, myofunctional therapy, guidance appliances, nothing in the fixed retainer category and nothing in a retainer category, because the last thing we want to do is hold that child where they are. We might have gotten them caught up, but now what about growing more? It would be like wearing the same size shoe all the way through your childhood. That's inappropriate. Well, why is it fine in the mouth? So we don't put a size of retainer in a child's mouth and say we're good, because now we're holding something where it is undersized as that child is growing. So no retainers for kids, techniques that involve growing and developing going forward. And the good news is we have an entire course on that.
Well, that was the next question. So are all these appliances discussed in his mini residency? Michelle wants to know. So the good news is yes. That's
Yes.
why we built it, because we have so many questions come in, and you do such a good job at explaining the problem, the epidemic of our jaw shrinking and the underdevelopment. And then so many people want to know how to implement this. So here's the birth of Airway Health Solutions that we created 2 years ago. I know Howie's trying to join us, but we have time for a couple more questions. If expansion did not
Okay.
occur by age 13 and have impacted canines and or lower bicuspids impacted, what next?
Oh, 13 to 19, we do plenty of fixed expanders. And so right there from 13, we showed you actually the 2 fixed expanders on that, I call it child, but she was 16 going on 17 with teeth trapped and impacted and locked out. And of course, already being told extraction. The idea there is it's still foundation first. So it doesn't matter what tooth is impacted or what tooth is horizontal or who's trapped. Foundation first, and then the techniques are put in place to bring those teeth in. So do we have to have surgeons expose teeth and chain them? Absolutely. And so when we meet these kids who are 13, 14, and there's a canine sitting up there or a central sitting up into the nasal floor, we get chains on those teeth and bring them in. So expanders are first because you need the foundation size. With all of that size comes the opportunity to install some very nice self-ligating brackets with really broad arch wires to keep that arch separated and little springs to develop the chambers for the teeth that are, let's say, impacted. Once we have all that space, foundation first, space where teeth should be, the surgeon goes and chains those teeth and we bring them in. So we never sacrifice a tooth, but when we focus on foundation first, teeth second, all of those teeth have the opportunity to be brought in. And it's just then a matter of adding the technique that that child needs. Happy to bring those teeth in. We do a lot of that.
What would you say the age limit is for adult expansion?
Adult expansion. So we've been doing that into the 60s. I've yet to do that on 70 or older. So there isn't really an age limit. And the interesting thing about the maxilla is that the maxillary sutures don't really go through a full fusion. They mature. And when you look into all of your orthopedic textbooks and you talk to your orthopedic surgeons and you learn a little more about the maxilla, it's not as short and simple as, oh yeah, it's fused and you can't do anything about it. Well, you can actually use removable expanders all the way through the 7th decade because the maxillary sutures don't fully mature until 7 decades later. It's a whole lot different than the cranium. So right up above the maxilla is the cranium. These sutures fuse early and they go through full fusion. These are locked. So all of the sutures and fontanelles that make up the skull fuse, they begin at age 3. That fusion begins at age 3 and seals off by 2025. So we get the cranium fully fused, locked in place, holding that brain. Interesting thing about the maxilla is that that's a dynamic bone. The maxilla can be adjusted at any age. So now you have this maxilla that has the first 6 decades of life where it can be remodeling. And why not help it grow? So same thing though, nasal hygiene, frenum release, muscle work, the myofunctional therapy works all the way through adulthood. So when you have your nice techniques in place, you can grow that maxilla and improve a patient's health at any age.
Oh, look who we have. Elegant
Hello.
Dr. Hindin. I just want to make sure your
Hi,
mic is on. Great.
can you hear me?
Welcome. I
Hi,
can hear
Howie.
you now. Hi, Dr. Hindin.
I can
How
hear
are
you.
So I stepped outside the restaurant in order to get on this call, but
We
I wanted to
appreciate
I wanted to wait till you
Thank
got
you.
all the bones in the brain fused
it.
Yes,
before
absolutely.
I interrupted you.
So,
Oh no, I'm
Although
happy to be
Dr.
interrupted.
although cranial osteopaths will say that the bones really never completely fuse, uh, but I'm
Hey,
glad that
that's okay with me.
I'm glad that you invited me, and I want to talk about O2 Day.
Please.
And I want to thank both of you for allowing me to come on. And Ben, you've been a part of our whole movement to make a difference in the world. So a number of years ago, we decided that the world's not going to change because practitioners are going to make a difference. It's going to be the public that's going to make the difference in the world. And that's why we created the Foundation for Airway Health. And so this year is our first Breathe-A-Thon. And for those of you who are old enough to remember, it's sort of taking after the old Jerry Lewis telethon. Ben, you remember the Jerry Lewis telethons?
Yes, yes. We used to watch that telethon. We would have it on. My parents had that
Right.
on the TV set. We were watching that.
So I had asked, I wanted to do a 24-hour event. My team said they can only do 6, so we settled for 12. So we're going to do 12 hours on Facebook Live. And I saw that, Lauren, you texted me that you reached 17,000 people, which is really great. As of this morning, we have reached 885,000 people in 88 countries for our webinar and for our Breathe-A-Thon. And our goal is to reach those people in the world who don't even know they have an airway problem, who are going and getting treatment for other things, whose children have learning problems, behavior problems, growth and development problems, and adults have all these chronic problems. We want to reach those people. And if we reach those people, we're going to need people like you, Ben, in order to provide care for them. You know, because it's always the demand that will grow first. So my goal, my dream is that by October 2nd, we reach 1 million people. We only have 115,000 to go. So if the people on this talk tonight, go to the Foundation for Airway Health, airwayhealth.org, and click on the O2 Day Global Airway Health and buy your virtual ticket. It will help us reach 1 million. And my goal was, if you remember, Ben, 2020, the 2020 special day, because 2020 is O2 backwards. That's double oxygen.
Yes.
And so that if we can reach 1 million people, that'll be fantastic. The other thing that might be interesting is I have asked practitioners around the world to donate a service, a screening, a case, or whatever they want to donate, because making airway better is a partnership between the public, practitioners, organizations, and corporations. And so far to date, as of this morning, we had $300,000 in services being donated by practitioners. All you have to do is go to the Foundation for Airway Health site, and find a place where you donate a service, fill out the form, what you want to donate, and your geographical area so people will know where to find you. And and we will add that to the list of donations. So that'll be great. So, and that's my spiel.
Well, it's wonderful. Thank you for the work you do. You know, for those who aren't familiar with, Dr. Hindin is president of the AAPMD. I'm a proud member. Dr. Miraglia is on the board. You have a wonderful meeting coming up in November, so I'll provide the follow-up links as well. So thank you for all your service, and we'll see you on O2 Day. You have some very prominent guests featured. James Nestor, right, from Breath will be there, correct? I don't know if you can hear me.
I can hear you. We have an incredible lineup. We have experts. We have people from around the world. We have success stories of people who have somehow, after visiting multiple doctors, have finally gotten to the practice of somebody who knows airway, be it a dentist, a myofunctional therapist, a physician, and had their life turned around. So we have success stories. We have celebrities, we have entertainment, and a lot of surprises. So it's going to be from 8 a.m. to 8 p.m. Pacific time, which is 11 a.m. to 11 p.m. Eastern time. I am going to be there for the whole 12 hours. And join us. Join me for an hour, for 2 hours. Come and go. And anybody you know who may have an airway problem, ask them to tune in. It could change their life. It could save their life, which is what Lauren, you and Ben are really doing. It's not about expansion. It's about changing and saving people's lives. and I'm happy to have you on my team.
Well, thank you.
Thank
Thank you so
you.
much. We appreciate your time, and we'll see you on Friday, O2 Day.
Great.
Yeah.
Thank you.
Thank
Very
you.
good. Thank you, Howie. Thank you very
All
much.
right.
Thank you.
Yeah, I've seen that lineup, and I know most of those people. That's an
Ah.
impressive lineup. That's a who's who list from around the world that work in this field, and
Absolutely.
in every single specialty that could be related to it. And it's going to be an amazing day. As much as you could
Exciting.
watch of that day, you won't be disappointed.
Well, Ben, I think we could have a 12-hour on here with all the questions that are coming in, but I want to be mindful and stay true to time. But we will definitely do this again because there's tremendous interest and there's so much to learn.
Yeah.
Consider if you're really interested in saving lives and doing more than just drill and fill, and that gets old, you really enjoy helping people, consider taking our mini residency so you can implement this right away. We have some great testimonial videos on our website so you can learn from your peers as well. We want to thank Ohlendorf Labs for sponsoring this with us, and they're great partners. So thank you, and reach out to